I hope that you all are doing well. Tonight, we're going to be talking about assessment and planning. Um, but we're going to be talking about it from the standpoint of diagnosis and medication. I'm going to go over just a few slides before we hop into the questions. Like always, we do have a poll. I'm going to put the link in the chat. If you click it, it will have the first question. So if you want to answer it while I'm talking, that's fine. But we're going to get to that question in just a second. I just wanted to show you some of the kind of new additions that I added, like I did last time, for the new exam. So we know that the exam has new categories, right? We have values and ethics, assessment and planning, intervention and practice. So all of the exams have the same exact content in terms of the three categories, but of course are going to be looking at them just a little bit differently. Um, on exams in the past, there has not been a plethora of diagnosis. I feel like that is just kind of like our go-to is to be able to study disorders. I think that's just our go-to because the profession in general is just really fixated and very clinically, heavily clinically based. And so that's kind of our go-to. So I would not, the same way it really wasn't on the last exam, I don't think it'll be heavily on this exam in terms of diagnosing. I think it will play a part for sure in your assessment, kind of what you're looking for, and typically will be a part of your presenting problem, right? Your presenting problem typically will have a disorder in it. So it's going to be based on um, kind of those factors. So I wanted to just do like I have been doing for every kind of topic, kind of looking at the master's exam and the clinical exam. I'm so sorry, I don't know what that was. Oh no. I hit something and then something popped up. Okay. I don't know. Okay, so for the master's exam, we have recognizing common indicators. Okay, similar to what I always used to say, it's more about recognizing the symptoms, making sure that you're looking at all of the symptoms that are present in the scenario. Of course, part of assessing for a emotional or mental health disorder may require additional assessment. We talked about that a little bit last week. Looking at the impact of co-occurring disorders. We looked at that a little bit last week as well. And then looking at the purpose and common side effects of medications. So all of that is kind of what you'll see, very kind of surface level, right? Really understanding the key features of a disorder. Whereas the clinical exam is going to look more at how to differentiate disorders. So you have to know a little bit more than just the key features. You're going to want to know also kind of how certain disorders may present similar to other ones and how to distinguish them. You're also going to want to integrate DSM findings into your clinical formulation. So, in terms of how you're going to approach the client, you want to, of course, um, really understand how the DSM-5 kind of plays a role in how you're treating the client. Same with the side effects for the medication. Um, and both we know that we need to rule out medical conditions, substance use, and medication effects before we say, okay, this is definitely a mental health, mental disorder or emotional disorder. Um, So I wanted to just remind you that you always want to rule out medical first. That's something that we talked a little bit about last week. But anytime that you're looking at an emotional or mental health disorder, you want to, if you see some physical symptoms, some mental health disorders do impact those kind of psychosomatic, right? Symptoms. For example, anxiety, you may have some racing of your heart a little bit with anxiety, right? Have that elevated heart rate. That could be due to anxiety or that could be due to something that's medical, right? And so, really understanding and making sure that the client has kind of ruled that out with their physician. You don't necessarily need to know these different things. But just this slide is just saying, hey, before we consider if the symptoms are related or caused by a mental health disorder, we want to make sure that we are ruling out that medical side as well. Um, I think last week we had one about that urinary tract infection, how sometimes in older adults that can present as like dementia or delirium, but it really could just be a urinary tract infection. So we talked about that a little bit last week. So I just put that in here. Um, when it comes to our mental health disorders, we want to make sure we are assessing. I keep saying presenting problem because that is why the client is seeking services, but we also want to understand the duration and onset, right? When did the symptoms begin and how long have they lasted? We also want to know what the symptoms are and also the intensity and frequency, which is similar to like duration and onset. Um, and sometimes we want to know like what's happening now. We may also want to know what the history of the symptoms have been if maybe they've had these symptoms for a while. So I just wanted to point that out for this slide. And then for my clinical test takers, I just included several slides about differential diagnosis. So differential diagnosis is the process of distinguishing one disorder from another when symptoms overlap. It's really important in the DSM-5 TR. It shows what some of those differential diagnoses could be. Right, kind of in that intro before you get to the criteria, it'll kind of give you common disorders to look for if you are trying to determine whether your client has this, right? And then it'll give you the criteria. So important to really understand kind of that clinical judgment and being able to rule out based upon several things. So I'm not saying that the master's level you can't differentially diagnose, but it's going to be more focused on the clinical exam than it is the master's level, because the master's level is just going to really look at symptom recognition. And again, um, in the past, on all exams, there has not been a plethora of diagnosing. Your disorders will be in the scenario for sure. But in terms of you distinguishing and saying this is the disorder that the client has, normally those types of questions are limited. But of course, we're not really sure how this new version in August will look. Any questions before we get started with our practice questions? I just wanted to kind of roll through that really quickly. I'm gonna pull up the QR code. I already put the polling link in there, but I also wanted to pull up the QR code just in case you're using maybe your phone or something, and that helps. That's helpful for the poll. All right. Anyone having issues with the poll tonight with the link?
Yes.
Okay. I'm gonna display it on the UR. Okay. I'm gonna display it on the screen and then I'm also going to I think I already did this. Did I already do this? Oh yeah, I already put the handout in the chat, but I'll put it again just in case. All right. This one's a shorter one, so we can kind of move through this one. This question was about the changes in the DSM-5 TR, and the answer is D. When it says accept, you kind of have to do your process of elimination in a backwards way. So you want to actually eliminate what is true or what was a change. So A, B, and C were all changes that occurred in this last revision. D um, did not occur. This was reclassified under a single umbrella term, and this change was already present in the five. So it wasn't a change in the TR. That was a change that happened, a revision before that. A, B, and C all reflect updates that are consistent with the TR. Inclusion of prolonged grief disorder, an addition of a symptom severity scale for anxiety disorders, and then a change in terminology from gender identity disorder to gender dysphoria. And then I also included a video and I have a DSM-5 TR quick study guide. I'm not sure how much it is now. It used to be like $8, so it's probably like maybe 10 or 13 now. But it's just a snapshot of the disorders. And so if that's something that helps you as you may encounter some disorders that you haven't heard of or not familiar with, it's just like very quick information about it. Um, so that can be helpful for your studying. All right, let's do number two.
Dr. Boone, on the rec poll on my phone, it just says thank you for your vote. Stay tuned for the next question. Oh, there it is. Thank you.
You're welcome. All right. So this one we're gonna do gonna go through it together just to remind you of the liked method. So last sentence first, the child most likely. A father brings his 9-year-old daughter to see a social worker because she has developed a habit of repeatedly touching her genital area during class and at home. Her teacher reports that other students have begun to tease her, which has embarrassed her. The father states that both he and the school counselor have explained that the behavior is not appropriate in public settings, but the behavior continues. There are no indications of sexual abuse or medical concerns. So when it says most likely, you want to really match the symptoms or the description in the scenario to the answers. So we can get rid of A, sexually abused, because it says there's no indication of sexual abuse. Um, so we can get rid of that. And then we have is attempting to gain attention from her classmates or is exhibiting anxiety-induced repetitive behavior. So we can get rid of B because we see that the students in her class have actually begun to tease her, but the behavior still exists. And so typically, you know, children don't want to be teased. So, if that was something that could be controlled, then I'm pretty sure she would stop. So the answer is C, exhibiting anxiety-induced repetitive behavior, right? So that embarrassment rules out B, and the sexual abuse is ruled out because there are no indicators of sexual abuse. So perfect. I'm going to change screens just because I am going to do something real quick, but let me change it on the poll for those that are using the poll. And then let me go. All right. So the liked method is last sentence first. Identify the key concepts. I'm sorry. Hold on. Identify the type of question. Key concepts. Eliminate it until you are left with two answers and the distractor. So all of these are going to be diagnosis and medication. So that part is pretty easy in terms of identifying the type of question. The last sentence typically will give you kind of more of a focus of what to look for. Um, and then our key concepts, I try to put that in blue. Um, and then the answer is also in that kind of teal blue color. My distractor is typically in yellow. And then what I eliminated first is in red. So I kind of do the liked method in with the colors, basically. So according to the epidemiological findings referenced in the DSM-5 TR, which characteristic is more commonly observed in individuals with substance or medication-induced depressive disorder? And the answer is they are more likely to be male. So this is just an example of a question that I found on the exam. I call them like prevalence questions. It's based on some research that it's like who is memorizing research. So unless you're just familiar with the population or maybe the disorder, just are familiar with the statistics on it, then um, you might know. I always say this is like a type of question that you would answer and move along. Like, don't spend too much time on this. There's no amount of information that you're going to remember to get this right. You either kind of know it or you don't, or you're just going to take a really good educated guess. Um, and so the research cited in the DSM-5, so they have a prevalence section typically before you get to the criteria, and it'll tell you like some nuances about how this presents in certain like categories. And so with individuals that have substance or medication-induced depressive disorder, they're more likely to be male, have a lower socioeconomic status, and have higher rates of substance use disorders compared with individuals who have major depressive disorder without substance involvement. Um, and so I just wanted to give you an example of that type of question. All right, let's move forward to the
Can you post the link again, the QR code?
yeah. All right. Which diagnosis best fits this presentation? Okay, so let's kind of look at what the presentation is. We have a serious car accident in which another driver was severely injured. The client is reporting being emotionally numb, having repeated intrusive memories of the crash, difficulty sleeping, having loud noises make her jump, avoiding driving, so avoiding that kind of trauma stressor. She's visibly distressed, and when discussing the accident, reports feeling detached. Um, Her symptoms begin shortly after the accident. Okay, symptoms begin shortly after the accident. All right. So the answer would be B. I know this one was a little bit difficult just because it doesn't give like an exact um time frame in terms of duration. And so that might be why we were kind of in between B and C. So B and C are kind of a good one to differentiate between, and it's really just going to be based on the time frame. So in order for it to be PTSD, it's going to have to require symptoms persisting longer than 1 month, whereas adjustment disorder does not involve a trauma-specific symptom, right? So when we see that trauma stressor, which would be the accident, we know that it's either B or C, and then we have to look at the duration. So acute stress disorder is 3 days to 1 month. And it says symptoms began shortly after the diagnosis. If it would have said it persisted longer than 1 month, then we would want to look at PTSD.
Can you repeat that again regarding the adjustment disorder? You say it does not involve trauma.
Right. So for both acute stress and post-traumatic stress disorder, you have to have a trauma, and both of them are going to be like a life or death trauma that either happened to you or that you witnessed. So with adjustment disorder, you could have adjustment disorder because you moved. You could have adjustment disorder because maybe your environment is changing, but it's not necessarily the level or severity of acute stress or post-traumatic stress. So adjustment disorder does not involve like a a trauma
Okay.
specific thing. Something they're definitely, processing and going through, but not like a life or death type of situation. So typically with acute stress and post-traumatic stress, you'll see things like accidents. You might see things like a disaster, a kidnapping. It could be sexual abuse. We often, of course, think of military. So things in which we have those life or death. Again, it can be something they've experienced personally or something that they've witnessed. That was also, it has to also be kind of like that life or death type of incident.
So, example for the adjustment disorder would be the parents divorcing. Would that kind of be like, let's say if it wasn't a volatile type relationship, but they did divorce and so they separated houses. That's would be more along the sides of adjustment versus the um acute stress disorder.
Yes. An adjustment disorder typically is like naturally we adjust to changes, but adjustment disorder, although it is temporary, you're going to find that the symptoms are going to be disproportionate to what happened. So, for example, maybe I have lost like 3 jobs in the past month. Like I just my job, I keep missing out on jobs. Um, So obviously I'm going to be upset. I'm going to have, some type of reaction to that, which would be normal. But once it starts to impact my functioning, um, and my reaction to it is going to be like disproportionate to what happened. So I might sleep on the couch for, a long period of time. I might have crying episodes. I might have like all of these different reactions, not to rise to the level of um depression or anything like that, but it's going to be specific to some type of event that happened, not life-threatening event, but an event that happened, right? That I'm adjusting to, but it's impacting my functioning. And it typically is going to be a shorter time frame as well. So let me see. Hold on one second. Because I don't worry, I got slides on top of slides for this stuff. Let me see, did I put it in here? So let's go to the next question. I'm gonna post the next question on the poll. Um, and I'll keep it on here too. And then I'll bring up the slide for adjustment disorder so we can look at the differences for that as well. All right, which of the following statements correctly differentiates between bipolar 1 and bipolar 2? Right? So what is the difference between bipolar 1 and bipolar 2? Which one is more severe? Which one is characterized by that mania, right? It's really the one that you want to pick out. And the answer is going to be C. Bipolar 1 involves at least one manic episode. So by nature is more severe because a manic episode is more severe than a hypomanic episode. Bipolar 2 involves at least one hypomanic episode and one major depressive episode. So the answer is C. Yep, and majority got it right on the poll. Good job. So I'm just going to switch really quickly so we can look at the difference. And the reason why you probably are looking at this let me present it so it's big. Looking at this is because they're all under trauma and related stressor disorder. So they're all in under the same category. So understanding the differences between these three is good. So adjustment disorder develops in response to a stressor through emotional or behavioral symptoms. It's marked with distress that is out of proportion to the severity or intensity of the stressor. So again, losing a job is definitely hard. right? But if my response, right, is not allowing me to, like, maybe I'm not leaving the house, you know, and I'm having a distress that is out of proportion to the stressor that is happening to me. It could also be a breakup. Maybe I experienced a breakup, but it is out of proportion and it's impairing my functioning. Remember, when it comes to mental health disorders, that's normally a key criteria. It occurs within the within 3 months of the stressor. So if it begins to persist, then we're going to look at a different disorder, right? So adjustment disorder says, hey, if we're having this distress, right? Distress is fine, right? But it's when it is out of proportion to the severity or intensity of the stressor. And you can definitely understand why external context and cultural factors should definitely be um, influence our assessment too, right? Because there are things that may be characteristic of maybe that family's culture or that person's culture that we should take into account, right? So we shouldn't be like, oh, that's definitely out of proportion, but maybe that is a norm in the culture. So you do have to take that into account. But it's the distress and it's also the impairment in functioning in work, school, or socially. Once the stressor or its consequences have terminated, the symptoms aren't going to last, right? Because if they are lasting, then we want to maybe look at something else, maybe major depressive, or we might want to look at it, some other type of anxiety disorder, or whatever. You know, we want to look at something else. But adjustment is in response to a stressor out of proportion to severity or intensity of the stressor occurs within 3 months. So we know it's coming from the stressor, right? It's not just something that always has been there, but has occurred because of this stressor. And then if we go back to post-traumatic stress, you know, has so many things going on, right? Involved in or witnessed a traumatic event and survived. And then these are some of the type of events you may see at the bottom. Accidents, combat, disasters, sexual abuse, rape, kidnapping, hostage situation, anything that is like a life or death kind of scenario is what I always say. You'll see that it is followed by a lot of things like intrusive, distressing, maybe memories, flashbacks. You're avoiding the stimuli. We saw that in the scenario. Um, it might impact your mood or cognition, your ability to remember. Um, you might also have diminished interest of participating in things that you might have used to participate in before. You might feel a detached because of your response to that life or death situation. Um, and then it's evidenced by two of the following: anger outbursts, hypervigilance, reckless or destructive behavior. Maybe you have a startle response or problems with concentration or sleep disturbance, right? But it has to happen more than 1 month and significantly impair your functioning. Acute stress is going to have all of those same symptoms, right? Meets the criteria for PTSD except for the duration. The symptoms must occur for a minimum of 3 days and resolve within 4 weeks. So those are kind of those three.
I can see how someone can get mixed up between PTSD and adjustment disability based upon the symptoms and the PTSD individual exhibiting, but it has a lot to do with like the time frame.
Yes.
So with the acute distress disorders, 3 days to a month after the trauma, and then with the adjustment disorder starts within 3 months, and then
Yes.
ends within 6 months of the stress and removal.
Yes.
And then with the PTSD at least 1 month. So I guess you would put the stress disorder first, and then like the PTSD, kind of like if it's within that month, and then the adjustment disorder would kind of like be the last.
Yeah, and you're going to see different behaviors, right? Because remember with PTSD and acute stress, it has to have all of those things we just talked about, right? Flashbacks. It's almost like you are what we would call traumatized, right, from what you've just gone through. Whereas adjustment disorder is not necessarily that you're traumatized and you're having flashbacks and like it's not trauma specific. It's more about your emotional response to what has happened is impacting your functioning and it doesn't really match what just occurred in terms of the stressor. So you're going to see different types of behaviors, right? PTSD and acute stress is very specific in terms of what we just talked about, sleep disturbance, flashbacks, not remembering, right? Having issues remembering, avoiding the stimuli. Like all of those things will be present where those things will not be present in adjustment. Right? Adjustment is just going to say, "Hey, I lost my job and I'm not getting off the couch." Right? Like I'm not eating, I'm not getting off the couch. And it's not because I'm traumatized, it's just because I'm having like a bigger distress reaction than what matches the stressor. And so it's not normal adjustment. You know what I mean? It's not like, oh, okay, that person's just adjusting. It is taking much longer than normal, right? I mean, they give you some time, but then it's like, okay, it's impacting your functioning and it's not really matching what happened to you, right? It's a stressor, but it's not as severe as acute and PTSD. So one of the things I would say definitely to distinguish between those two is going to be what happened, right? If you see what happened, it's a change that, people can have emotions towards, okay. But if you see it's a traumatic event that is a life or death situation, then you're looking more at acute or PTSD versus adjustment. So hopefully that was helpful. What I can do is when I send out the follow-up with like the recording and everything, I'll send some examples of where the answer is adjustment disorder. If we don't have some tonight, because I can't remember. I think we have one tonight. So let's hold on. I think we do have one tonight. But I'll send some more examples so that you can kind of see and see how they present differently. But great questions. Love it. Okay, let's go to the next question. I'm gonna put it on the poll, but I'm also gonna read through it, um, just so that we can kind of move through as many as we can get through. What is the most likely clinical presentation? If you do better when I don't talk and you just read it to yourself, just put me on mute for a second. Um, a 20-year-old graphic designer comes to therapy after a recent conflict with her partner who expressed concern about her recent behaviors. Over the past 5 days, the client has been sleeping only 3 to 4 hours a night, but reports feeling more energetic than usual. She says she's been hyper-focused on launching a new creative project, working around the clock without feeling tired. She has been unusually talkative in meetings and more social than normal, but denies hallucinations or delusions and says she doesn't feel distressed, only productive and a bit impulsive. Her mood appears elevated, but she is cooperative and oriented. What is the most likely clinical presentation? Is this manic episode, hypomanic episode, or generalized anxiety disorder? Let's see those answers. Can anyone tell me the difference between manic and hypomanic? Okay, the answer is hypomanic. And the reason we can rule out manic is because it says that she denies hallucinations or delusions. And she seems to be still functioning, right? She's still functioning. Um, and it has not resulted in any type of hospitalization, to denote a severity that would rise to the level of manic episode. The reason why it's not C, let me see, does it say? The reason why it's not C is because it is talking about mood. So what you'll see is that this is where I was talking about knowing, it's hard, it's important to know the key features and not get stuck on some common ones, right? Lack of sleep is a key feature I mean is a symptom in a lot of disorders in the DSM-5, right? So you can't just go based off of the client's not sleeping, right? Because you could say, okay, the client's having a sleep disturbance, right? Impulsivity is also something that occurs in a lot of disorders. So you can't go based upon that. If we're dealing with generalized anxiety disorder, we're going to see some type of worrying, or concern about something. Um, but we don't really see that. We see more of a mood, right? You see that she is having an energetic, right, mood. Um, and she's really highly productive. Typically, hypomanic episodes can be good sometimes. Unusually talkative. So again, that elevated mood is what you're seeing. Doesn't feel distressed also is something that okay, we're not into um that manic zone. So when we look at this, I'm just going to skip past just so we can see. Manic episode and hypomanic episode have the same exact 7 symptoms. However, manic episode has to last at least 1 week, okay? Whereas hypomanic lasts at least 4 days. You both need three or more, must be present out of the 7. We see this self-esteem, grandiosity, decreased need for sleep, more talkative than usual, flight of ideas, right? Creating a new project. Um, I can understand why you might think anxiety, right? Because it says thoughts are racing, right? Which can be GAD as well. Distractibility, increased and goal-directed activity, excessive involvement in activities that have high potential for painful consequences. You'll typically see that with manic for sure. But the difference is going to be here where we look at the severity, right? If the mood disturbance is sufficiently severe to cause marked impairment or to necessitate hospitalization, or there are psychotic features. All three of those things are pointing to manic. If you don't have marked impairment, you don't have a need to go to the hospital because of your symptoms, and there are no psychotic features, by definition, it cannot be manic, right? If those things are not there, then it's not manic. So we're looking at duration, and then we're looking at severity in terms of impairment to the client. Um, yeah, typically with hypomanic, they're just like really productive. But it's still, can be something that we definitely want to note. Again, manic is going to be more severe. Okay. Any questions on, we've gone through trauma related, bipolar, any questions on those so far? We are at 8 o'clock, but we'll probably go for another 15 minutes just to get some more questions in. Okay. And again, I'm going to read it out loud just so that we can kind of get to the question a little quicker. What is the best way for the social worker to evaluate the client for a possible psychotic disorder? A social worker conducts an intake assessment with a new client at an outpatient mental health center. The client reports feeling stressed and having difficulty sleeping, but provides only brief responses to initial questions. The social worker wants to observe the client's thought process, coherence, and possible signs of disorganized thinking. What is the best way for the client, for the social worker to evaluate the client? And remember, we want to observe the client's thought process, coherence, and to see if there's any signs of disorganized thinking. So, out of these four choices, what is going to be the best way to do that? Oh, the question is different. Oh no. Okay, it should be the same. It looks the same. Yeah, it looks like it's the same on here. Now, when we think of disorganized speech, um, mm, yeah, when we think about disorganized thinking or disorganized speech, what disorder are we thinking about? Yeah, schizo something, right? Yeah, schizoid, schizophrenia, schizo something, right? And that is an expressive, it has to do with your cognition. But in order to know what someone is thinking or if they have a skewed thought process, getting them talking is going to be the best way to figure out what's going on up here, right? Getting them to express will help us to assess. So, with that, the answer is D. Using primarily closed-ended questions, like yes or no, where we're just getting yes or no, um, might be good if we already knew that they had schizophrenia and we knew that they had disorganized thinking, then we might not want them to express themselves too much. But because we're trying to assess that, then we do want more talking, right? Ask the client whether they have previously been hospitalized for psychiatric care. That's a good question, but it's just not the best way to observe the client's thought process coherence. That's key, right? Observe the client's thought process, coherence, and signs of disorganized thinking. Again, speaking with family members, anything outside. So B and C are both outside the client. Yeah, so we can get, honestly, those two will probably be the first ones we would get rid of. And then between A and D, which one is going to give you the best way to evaluate if there's some type of skewed either delusion, hallucination, right? When we say psychotic, that's what we mean. So psychotic uh features are typically going to be hallucinations, delusions, disorganized speech, disorganized speech, anything really related to schizophrenia and all of the other psychotic, like anything in that category, those symptoms is what we're going to see. So typically when we are treating someone with schizophrenia, we might not want them to freely talk. But if we're trying to see if they have schizophrenia, getting them to talk is going to be the best way for us to see those speech patterns, to see if they might have like a word salad, which would indicate that they're having some issues with cognition or thought processes. So observing is really the key there. A limits our observation. So that's why A wouldn't be best because it limits our ability to really observe how that process is kind of manifesting their thought process. Okay, thinking about mental status exam. Yeah. All right, let's go to the next question. Again, I'm going to read it as you all work through it on the poll and on the screen. What is the most likely diagnosis? A 42-year-old man meets with a social worker stating that his coworkers are conspiring to have him fired. He reports that they secretly record his conversations, tamper with his desk, and spread false rumors about him. Despite a lack of evidence, he insists that his employer is involved in the plot. His functioning in other areas of life remains relatively intact, and he does not report hallucinations or significant mood disturbances. What is the most likely diagnosis? All right, we were pretty 50-50 on this one. We were split between B and C, delusional disorder or paranoid personality disorder. So the answer is B, delusional disorder, persecutory type. It is characterized by persistent false beliefs that one is being mistreated, spied on, conspired against without symptoms of schizophrenia. So we can get rid of A, that's easy. C is incorrect because while it does involve distrust and suspicion, it does not usually include fixed false beliefs. So again, although paranoid personality disorder does have distrust and suspicion, delusional disorder, the reason why this is different is because even when you give them evidence, they still do not believe the evidence and believe the false belief. So see where it says, despite a lack of evidence, like despite them being evidence that these things are happening, he still is saying this is happening. versus just having, remember, personality disorders are kind of like things that are part of kind of our personality, but like the bad parts, right? So you could have someone that's having that distrust or suspicion, but when you have something that is fixed, no matter what we say, that person is going to keep that false belief. But with delusional disorder, they typically are fine. They still go to work, they still function. It only has the disturbance only really comes when you try to tell them that that false belief is not real, right? When you try to um have a conflict with them or try to go against what they believe, then that's when they have distress. But other than that, they're fine, right? Because that's what they believe in and they continue to do what they do, but they are really, really focused on that. I wrote down to also show some questions on paranoid personality disorder so you can also see the difference between those two. So, delusional disorder, the key there is no matter what type of evidence you give them, they are not going to budge on that false belief. This specifically is persecutory type. I picked that because that's one of the more common types. But you can have a delusion about anything, right? I can believe I'm Beyonce. No matter how many times you tell me I'm not Beyonce, and I'm fine. I live my life like I'm Beyonce. I'm fine. But as soon as you try to challenge, that's the word, I could not get that word out. Challenge. As soon as you try to challenge my false belief, that's when I start getting distressed. But otherwise, typically with delusional disorder, they kind of function normal. And that's why it's not schizophrenia, because there's no hallucinations happening. There's no disorganized speech. There's no negative symptoms, right? None of that is present. So the schizophrenia is not present. Those symptoms are not present. It's only the delusion. Whereas paranoid is like, I don't really trust. I'm suspicious, you know, but it's not focused exclusively on a delusion like B is, like delusional disorder is. All right, let's do 9. What is the most appropriate diagnosis? A 35-year-old client with a diagnosis of schizophrenia reports experiencing hallucinations even when their mood is stable. They also describe periodic depressive episodes that last for several weeks. The hallucinations have occurred in the absence of mood symptoms. What is the most appropriate diagnosis? Bipolar 1, major depressive disorder with psychotic features, or schizoaffective disorder. All right, the answer is schizoaffective disorder. Schizoaffective disorder involves psychotic symptoms like hallucinations that occur independently of mood episodes. With major depressive disorder, the moods are going to be there all the time. So you're going to have major depressive disorder. Your mood, that depressive episode is going to stay, but the psychotic features are going to come in and out. With schizoaffective disorder, the schizophrenia stays and the mood comes in and out. Does that make
Right.
sense? Let me say it one more time. Schizoaffective, um, it's almost like go to the root word, right? So schizoaffective, the schizo is it is tricky. Schizoaffective, the psychotic symptoms occur independently of mood episodes. So with schizoaffective, you're going to have your schizophrenia and some mood happening on top of the schizophrenia. With major depressive, your major depression is going to stay kind of steady. It's almost like your depressive symptoms are stable, but then you're also going to have some maybe manic episodes um in there as well, or some kind of psychotic feature mixed in there. So the key here was that you were having hallucinations even in the absence of mood symptoms. So your hallucinations stayed and your mood kind of came in and out. So you might have been depressed a little bit, but your hallucinations stayed consistent. Your schizophrenic symptoms were stable, whereas the mood came in and out. I'm gonna add that one to my list too. Major depressive with psychotic features.
Could could you mention about the major depressive? Because when I put you on mute and I have to switch screens, I don't know when you're talking again. So I missed your explanation on the major depressive disorder.
Yeah, so I was just saying with major depressive disorder with psychotic features, the stable symptom is going to be your depression. Like basically, depression is not going away. Those symptoms of depression remain, and the psychotic features, the hallucinations, the delusions, disorganized speech, the negative symptoms are going to fluctuate. They'll come in and out. With schizoaffective, your schizophrenia is going to stay stable. So your in this case, it's hallucinations. The hallucinations are stable. Sometimes the mood is there, right? Sometimes there are periodic depressive episodes. So it's almost like I always say this is like different ingredients. So the major depressive episode, the manic episode, the hypomanic episode, they're all ingredients. And when you mix them, almost the order in which you mix them or the amount in which you mix them will give you different disorders. So schizoaffective is like a lot of schizophrenia with the little mood. Major depressive is like a lot of depressive with a little hallucination. It's like a little sprinkle. Um, But the main thing is going to be the schizophrenia. The main thing is going to be the major depressive with B. And then you're going to see some of those other symptoms fluctuate or come in and out.
I have a quick question.
Sure. Hey,
Could you
Maria.
explain a little bit? Hi, how are you? Hi.
Yeah.
Um, can you explain the bipolar one disorder when it comes to this formula? Because it makes sense now when you say like major depression disorder. Okay, it's more about the mood, and you get a little bit of the psychotic features, schizophrenic, schizoaffective. It's more of the the hallucinations, but the mood can fluctuate. So when it comes like bipolar one in this scenario, plus with bipolar two, like, can you help me understand that a little bit better?
Sure. So with bipolar, also you're gonna see that mood. So with bipolar, you're going to see those episodes, right? You're going to see depressive episode, you're going to see manic episode for bipolar 1. But because it talks about the schizophrenia, we can kind of go between B and C. Because bipolar 1 is different than schizophrenia.
Okay. Okay, that
Yeah,
makes sense.
the ingredients are a little different.
Okay. Okay, that
Um,
makes
But because we have the depressive and then we have the hallucination, which can come with manic, that also you'd be like, well, maybe it's bipolar 1, right?
sense.
So that can be confusing. But when it says the client has been diagnosed with schizophrenia, and now, so that's the base, and now we're like sprinkling in the mood. That's
Mm-hmm.
where we can get to schizoaffective because we
Okay.
already had a diagnosis of schizophrenia, and now all of a sudden we have some mood coming in, and that's where it becomes schizoaffective. And I think, okay, I don't know. Let me,
Thank you.
yes, let me just go to schizoaffective just so you can see like here it is. So schizoaffective, just because I'm visual, so I need to see it. Schizoaffective is viewed as a cross between schizophrenia and a mood disorder. So you have schizophrenia, and you could have a depressed mood, or you could have a bipolar mood. Um, it's going to be continuously, remember I said that stableness, continuous, exhibiting delusions, hallucination, or disorganized speech, whatever the poison is of the schizophrenia, that's constant. And then you may experience some of those other episodes on top of that constant schizophrenia presentation. So I'm gonna, because they all kind of go together and they are very confusing. Because you see, bipolar is listed here, but it's under schizoaffective, right? It's schizophrenia and mood mixed together, where bipolar is just categorized as a mood disorder only. So really understanding the difference between schizophrenia and the mood disorders may also help too. All right, we could probably fit in two more. I don't know how many I put on the poll. I think I have the next one on there. Hopefully. Let's see. We'll see. Okay, I do. I have the next one on there, so let's do 10. All right, the answer is A. Here we go. I knew I had adjustment in here somewhere. Adjustment disorder is characterized by the development well, we already kind of went over it, but I wanted you to see it. So you see, the woman has moved to a new city for a job, feels overwhelmed by the changes in her life, experiences frequent crying spells, difficulty concentrating at work, and a lack of interest in social activities, but the symptoms have been present for the past 2 months. Um, so the symptoms are significant because they are because of this stressor, right? Remember, typically with major depressive disorder, um, it's not necessarily tied to maybe just one thing. It might just be more of a kind of depressed mood or depressive symptoms, and we're looking at that time frame of the 2 weeks, and we're looking at all of those things, right? You have to have I believe it's three, if I can remember, 3 or 4 of the symptoms out of the list, right? Whereas adjustment disorder, we're not really looking at how many of the symptoms they have, right? We're not really checking off, okay, they have this one, this one, this one. It's more about, hey, we have this stressor, and they're kind of reacting almost like a little too much, right, to what's happening. Um, and it's within that time frame of the event that happened. The symptoms are significant, but they're not necessarily meeting the criteria at this time for another mental health disorder. Like it's not meeting the criteria for any of our depressive or anxiety disorders. The symptoms have caused some distress and impairment in some areas of functioning, which is part of the criteria for adjustment disorder. The time frame for MDD, hold on, major depressive episode is 2 weeks. Major depressive disorder is when you have at least one depressive episode. And then these are the criteria for the episodes. Sorry, going back some. Where's my list? Here it is. No, that's not it. Oh, five, sorry. Five. So for a major depressive episode, you have to have at least 5 symptoms present within a 2-week period. And one of the symptoms have to be diminished interest slash pleasure or a depressed mood, like sadness, crying, that sort of thing. So that has to be there, and you have to have at least 5. So weight change, appetite disturbance, sleep disturbance, difficulty concentrating. So it's almost like 5 is a lot, right? So you have to have all 5. Whereas adjustment disorder, we're not necessarily looking at counting them, and they typically with adjustment disorder, it's not this severe, but you may see some of that tied to that stressor. And I have more of the symptoms here, even though this is PDD, but we talked about appetite, sleep, energy, right? Low energy or fatigue, low self-esteem, poor concentration, feelings of hopelessness, right? But it has to be at least 5, has to be within the same 2-week period, and it has to be at least the diminished interest or the depressed mood has to be present within, in addition to 4 other ones. So we have to have appetite, sleep, um, energy, fatigue, all those things. All right, let's do one more. Let's squeeze in one more. This one. The most likely diagnosis for this child is a social worker is assigned to assess an 8-year-old child who is exhibiting impulsive and argumentative behaviors at home. The child has daily tantrums and refuses to follow any directions. This behavior has been ongoing for at least the past 6 months, at least once per week, and the parents believe that it is getting progressively more severe. The school reports minimal behavior problems and the child is earning positive grades. Perfect. The answer is D. Let's see how we did. Yeah, we did good. We did good. It's not C, conduct disorder, because remember, conduct disorder is going to be more severe. I think I do have, yeah, here we go. Conduct disorder is going to have, first of all, it's going to be 12 months. Conduct disorder is 12 months. So that's a dead giveaway. But also in terms of the behaviors, we're going to see violation of societal rules and societal norms. We're going to see aggressive behavior, harm to others or animals, property damage, deceitfulness or theft, serious violation of rules like on a criminal typical level. We might see deliberately setting fires. And then the impulse to steal is kleptomania. That's just some definitions. So that's what you're going to see. Definitely 12 months, three or more of the behaviors. And you're going to see them consistent in all settings, right? Whereas ODD typically is going to be more at home and sometimes that structure of the environment. Oh, here it is. The structure of the school environments typically do a little bit better in school. And it really is about more about being argumentative, not following rules, deliberately breaking rules, but not like crimes, right? Not crimes, but more whatever maybe rules you have set, like, you must clean your room before you watch TV or something like that. And you're going to see that irritability, that anger, losing temper, being annoyed, but not setting fires and not, you know, destroying property. So that's what you'll see more with conduct than ODD. All right, how are you feeling?
Okay.
And I want you to know the reason why it's supposed to be a uh, shorter class, but it's kind of the same. Because I just want to make sure you got some other questions in. There's a lot, I have a lot more questions for you because we only got to um hold on, let me go back to the right one. We only got to 11 and I have 19, no, I have a lot. No, I have 23 questions. So whatever 23 minus 11. So those are some additional questions you can go over. And then I have homework questions too. So I have a total of 35 questions for this handout. And we only did 11. So you have a lot for homework. Feeling good. Okay, good. And I want you to put it in perspective because remember, at least for the exam so far, you may get, I don't think I've heard anyone say they've gotten more than five on the master's exam in terms of diagnosing. And then on the clinical exam, you should expect some diagnosis on there, but typically my clinical test takers will be like, I thought it was going to be all diagnosis, and it's not. It's not all diagnosis. Um, so just keep that in mind as well. I would not have this area be a high study area, and I would not feel bad if you got some of these wrong. I would just review them just so you have them kind of fresh in your mind, maybe write them down. Um, but other than that, I wouldn't freak out too bad. But a good working understanding is definitely going to be good. I think for the clinical exam, definitely doing a deeper dive into the disorders is a good idea, but also understanding that your exam is not all disorders. It's going to be a lot more of that scenario based. Um, and then once we get to intervention and practice, which will be next week, we're going to be doing intervention and practice, which will include um, micro practice or direct practice with clients, and then also macro. So we'll do both next week. And then, so next week is August 4th. And then the week after that is August 11th. That'll be our last class where we'll go over all questions. Um, and I'll probably divide it up into no, I'm not going to divide them up. I'm going to mix them together so that you won't, so we're not going to divide them up into categories, but we'll identify which category it falls into when we go over the answers. I have opened up for those that didn't do the bundle and you just did a drop-in today. I have opened up a drop-in for the next two classes, if you're interested. But for those that have the bundle, I will see you next week. You're going to do 6 hours, 6 hours this week. If you haven't studied diagnosis and medication, you can go ahead and do that. Um, but if there are other areas that you feel needs more attention, ethics, or anything that we've done so far, human behavior, or just assessment in general, then I want you to review those things as we prepare for intervention and macro practice. But it was great seeing you all. I will send out the recording on Thursday/Friday morning.
Thank you.
You're welcome. And I hope you have a great night. I'm glad the rain stopped for those that were in Maryland and got the monsoon of rain. It seems to have calmed down a little. I will see you soon. See you next week. Keep studying. All right.